trials. Okay, we started to have some trials related to these genetic skin diseases, and that's very exciting. Just to take you back, I've been around long enough that I remember the age when I was doing my graduate work, and we were excited about banding on chromosomes. Well, we know that that's not the way it is now. We can do so much with genetics now, and I can only imagine what it's going to be like in another 10 years. So the late 1980s to now, we've had just an explosion of information about what underlies monogenic disorders. Back when I was a resident, I remember getting excited because we could, in the middle of a pregnancy, do a biopsy of the baby's skin and electron microscopy and make a diagnosis of epidermolysis bullosa. By the mid-1995s, we were able to do a DNA-based prenatal diagnosis. And of course, that can still be done now using very low-risk techniques like chorionic villus sampling, and do it early enough that you can make a decision, of course, still difficult, but at a time when you could terminate a pregnancy if necessary. There's still some ways to go with maternal blood, but boy, I hope that's the wave of the future in terms of really being able to get this diagnosis as easy as possible. But I know one of the things that we've done once we know that there's a genetic disease in the family has been pre-implantation diagnosis. This has been a way to assure that the babies of a couple who are at risk for having an offspring with one of these genetic disorders, particularly one that's going to have a tremendous impact on quality of life, can guarantee up front that the baby will be normal. And if you're not familiar with pre-implantation diagnosis, this is an in vitro fertilization technique where amazingly you can take a single cell from a blastomere phase, expand the DNA, decide which ones will be affected and which ones will just be unaffected or perhaps carriers, which is okay as well, and implant only the normal fertilized egg. And amazingly, the babies that result are just normal. Now, I want to remind you about whole exome sequencing and whole genome sequencing. Of course, these are techniques that now are in common use, but it's really just been over the last decade that they've been used quite a bit. The price for whole exome sequencing is now fairly low, particularly as a research tool, but originally it was an unbiased approach to discovery, then came into use now routinely for genetic diagnosis. I remind you that about 1% of the genome, but 90% of pathogenic mutations are in the exome, and that's why this technique is so valuable. For those in whom nothing can be found by whole exome sequencing, whole genome sequencing allows one to move on to detecting discovery in intronic regions, for example, that might impact exon splicing, and some others that may be in difficult to detect regions. So the impact has been this rapid expansion in understanding gene variants that underlie skin disorders in a way we never had possible before. And what's so beautiful about it too is that you don't just go from one possibility to another possibility to another possibility, which is what we used to do in the past, but actually can look at a whole panel of possible genes, and even, as I said, with whole exome sequencing, genes that you didn't even know were related. And the cost is markedly reduced. So for example, with epidermolysis bullosa, used to be that we would be doing immunomapping. We would decide whether the baby had EB simplex versus junctional EB versus dystrophic EB, and we would take that information and look for just those genes, or in the case, for example, of dystrophic EB, just collagen 7, and look at that gene using Sanger sequencing. The cost for just looking at collagen 7, which admittedly is a large gene, was $12,000. Now there's a panel, for example, of 28 genes that for just $3,000, one can look at all of them at the same time. We don't even do the immunofluorescence mapping anymore for diagnosis because of the fact that we know, even though it may take a little bit longer, usually takes about 4 weeks, sometimes a little shorter, we can get that information back and go on and talk with the family about the expectations for that particular baby. There are also panels available for several other groups of disorders. I'm showing you here some images of patients with different kinds of ichthyosis. So you have a collodion baby as shown here on the left, and you might say, wow, you know, there are several different types that may be affected here. And so having that information is very helpful in sorting out if it's a very rare form that's syndromic that can be associated with collodion baby, or whether you have a more classical lamellar ichthyosis or congenital ichthyosis from erythroderma. Now, the whole exome sequencing and this facility of trying to look at new genodermatoses has helped us to find some new ones. And I'm just going to point out a few that have been from the last 10 years or so. These are two patients of mine, actually, who looked very similar and had some unique characteristics, but were certainly in the group of an erythrokeratodermia, what we might call progressive symmetric erythrokeratodermia. For example, the little boy at the bottom had nothing really to note at birth, but by 9 months of age had this darkening of the skin around the mouth, and as you can see here in the fold areas like the axillary area, and then progressively got more thickening and pigmentation. And I want to point out as well the white nails that are shown here, which is a characteristic feature of this particular form that has only been described in a few patients, but is due to the variants in the connexin gene GJA1 encoding connexin 43. It's a dominant disorder. And after this was described in these two patients, I had somebody else who walked in just to see me in clinic. But I could see these specific characteristics, knew exactly what he had, and all because of the recent recognition of this disorder. Another example, staying in the realm of ichthyosis, is a progressive symmetric erythrokeratodermia that's of a very different type. And some of these patients, but not all, have this very distinct involvement of the face. Palms and soles tend to be frequently thickened and erythematous. You can see that there's some involvement on the knees. And I want to point out in particular this somewhat distinctive pattern surrounding the genital area there of erythema and pretty marked thickening of that perianal area. And the reason I point this out is because these patients all have now been shown to have variants in a gene called ketodihydrosphingosine reductase, or KSDR, which is very important early in the de novo pathway for the synthesis of ceramides. Some patients have thrombocytopenia and fairly mild skin changes. Others have no thrombocytopenia. For example, the two patients of mine here I'm showing you never have had any thrombocytopenia. But these patients have an autosomal recessive disorder. In fact, for example, the girl in the upper left had to go to whole genome sequencing to find that second genetic variant. So sometimes hard to detect. But one of the reasons I want to point out this picture on the bottom right showing that genital area is because one of my colleagues in one of our divisional meetings showed a picture that looked very similar. That patient did not have thrombocytopenia, did not have facial involvement, had very mild changes on the palms, so not even recognizable, but it was this genital area that I took one look at and said, I think it's a variant in KSDR. So we need to be thinking about these new possibilities. Now, here's a form that we now know to be explaining what used to be called autosomal dominant lamellar ichthyosis. These are variants in a gene called ASPRV1 that encodes the skin-specific retroviral-like aspartic protease, or SASP-ACE. And what I want to point out here on this boy, as you can see, this patient of mine on the left who has what looks, if anything, more like a lamellar ichthyosis kind of picture. But interestingly, you look at his palmar markings, and they're very reminiscent of a severe form of ichthyosis vulgaris. You can see the marked palmar hyperlinear markings. Oops, I'm sorry, wrong one. And it turns out that the function of SASP-ACE is to cleave the linker peptides between the individual filaggrin monomers. So a more severe disease than ichthyosis vulgaris, but it kind of makes sense that it involves filaggrin, why you might get these hyperlinear palms that look very much like severe ichthyosis vulgaris, but a much more severe skin phenotype than we usually see even with homozygous forms of ichthyosis vulgaris. And this dominant mutation then leads to this combination of features. So keep it in mind. I think a lot of these patients are misdiagnosed. And by the way, I've seen a milder case than this young boy who went through for several years being diagnosed with ichthyosis vulgaris. Now, what about some of the syndromics? Well, actually, there is a syndromic form of EB simplex that more recently has been described through some of these types of research. This is the EB simplex form from defective keratin-14 ubiquination, and therefore there's increased degradation. This is always in a gene called KLHL24, and in fact, in a very specific location at the start codon of this. And the reason I'm wanting to make sure you're aware of this one is that these patients will be told you have a form of EB simplex. They do have nail dystrophy. It's a fairly mild form of EB simplex with small, somewhat limited blistering. This is one of my patients I'm showing you here in the top two images and on that hand. And she very early on had this dyspigmented appearance to her skin, continues to have that now. These patients have been shown to have an increased risk of cardiomyopathy, particularly as they get into adulthood, and maybe have more than that. It's fairly recently described. My patient has some neuropathic changes. I want to remind you as well about the new classification of epidermolysis bullosa that came out in 2020, as cited here. And as you can see, this new form is included, as are a few other newer forms, and there is a renaming of many of these. Gone are virtually all of the old eponyms that were associated with these forms of epidermolysis bullosa. Now, not just rare diseases, but also common diseases can have a basis that is genetic. So this is a severe form of atopic dermatitis. Some of the patients just have severe atopic dermatitis. Some have associated molluscum, as shown here in this patient. These are due to dominant negative hypomorphic mutations in CARD11. So in other words, it's a dominant disorder that gives you these manifestations. And what's happening here is a blocked activation of NF-kappa B and the mTORC pathway. What you have is a skewing towards a Th2 phenotype, a reduction in the Th1 pathway signaling, very much like what we see in atopic dermatitis in children. It's interesting, with this particular disorder, glutamine oral administration rescued the T cell proliferation abnormality and the interferon gamma insufficient secretion. And in fact, this has led to a trial that's going on now, trying to look at glutamine administration for more severe atopic dermatitis. I will say that there have been a few others like this that have been associated with atopic dermatitis. I'm not showing it here, but I want to point out that gain of function mutations in JAK1 are now described as probably not rare underlying atopic dermatitis, so another monogenic situation. Now, interestingly, dominant loss of function mutations in CARD14 can also give you severe atopic dermatitis. They tend to be associated with Staph aureus infection. And here again, you have a blockade that alters your T helper signaling pathways, including a reduction here of Th17 signaling and production then of your antimicrobial peptides, which is probably associated with this Staph aureus infection, or at least contributing to it as well. Now, you may look at this patient on the right and say, CARD14, hey, isn't that associated with psoriasis and pityriasis rubra-pilaris? And the answer is absolutely. CARD14 was found to be the same as SOR2, described many years ago as a locus associated with psoriasis. And we now know that having gain of function mutations in CARD14, not loss of function as in atopic dermatitis, but gain of function can give you a variety of papulosquamous disorders. In my experience, most commonly pityriasis rubra-pilaris, but also some patients who may have some somewhat atypical forms of psoriasis, but even generalized pustular psoriasis and acute generalized exanthematous pustulosis have been associated with these gain of function mutations in CARD14. I'm going to show you one of my patients. This is a boy on the left who came in with erythrodermic psoriasis. If you look closely, or at least I could see a few little foci of some pustules as well. We got him under control with systemic medication, but not fully. And when he came back in one day, he brought his little brother with him. And I was amazed because as he was looking at this time on systemic medications, which partially treated, got the erythrodermic component under control, but left him still with what was psoriasis, looked very much like what his brother had. And it turns out that they were both affected by having increases in CARD14. At this point, looked a little bit more like an atypical pityriasis rubripilaris. These are some images from a publication out of Israel in which within the same family, there were patients with generalized pustular psoriasis, what looked more like psoriasis, and what might looked a little bit more like PRP with this follicular accentuation over the elbows and knees. And this is just showing you that the gain of function pathway leads to this activation, including of increases in the pathway towards Th17 and Th23, which of course we think of as both being involved in PRP and plaque psoriasis. I want to say a little bit more about CARD14 to make sure that you think about it and recognize it if you see patients with it. As opposed to most forms of psoriasis or PRP, there's a very early onset of disease. Actually, most had the onset in the first year of life. It tends to also be more recalcitrant to treatment, and there's no remission without treatment. Often has some combination of features of psoriasis and PRP, sometimes, as I showed you before, even erythrodermic psoriasis. But many of these patients have prominent facial involvement, with the ears affected, the cheeks, and the chin. Usually it spares the periorbital area, but some severely affected patients may have involvement of the entire face, and as in this boy that I'm showing you, have ectropion. So this boy was misdiagnosed for years as having a form of ichthyosis, a congenital ichthyosiform erythroderma, or as he started to get some white spots, as we can see, of course, as zones of clearance with PRP, it was actually diagnosed then as an ichthyosis with confetti form because they thought this was Revertant mosaicism, and probably was, but not related to a keratin mutation in that case. Now, there's also usually truncal involvement. It may be patterned. I look at these and say, oh my gosh, this is so beautiful. And these patients do sometimes have this very distinct patterning. Notice that this boys follow along defined skin lines. But I would say over on the right here, notice these skip areas, again, consistent with what we might think about for PRP. Now, I also want to mention the progress that's occurred with mosaic defects. Of course, to look at them, we might look at lesional versus genomic, and that's how it's done. But I do remind you that when we're using techniques like whole exome sequencing, we all have many variants in our genes. They're going to show up when we're doing this. And so it then becomes a little tricky, even looking at lesional versus genomic sometimes, to try to find out what we're talking about that really makes sense for the defect. Here's an example of a mosaic defect that some of the newer technologies allowed us to be thinking about what's underlying it. Now, I'm going to look at this. I'm going to look at it with you. And I know you can't respond to me, but I want you to be thinking about what your diagnosis is. Now, I looked at this clinically, and I thought, this is inflammatory linear verrucous epidermal nevus. Well, indeed, it is. But what we found here histologically was evidence of linear porokeratosis. And I'm going to tell you that when we first looked histologically, we didn't see evidence of these cornoid lamella. It took sequencing serially to find this. We at first thought it's Ilven and didn't see this until the genetic analysis moved forward. And the genetic analysis showed, in fact, that this young girl had what we call type 2 mosaicism, as defined by Rudy Hopla. And here you can see that in type 1 mosaicism, the rest of the cells other than what are in that streak have a normal, healthy genotype. But in type 2 mosaicism, there's a background of a genetic change that's in every cell that may not at all have manifested anything yet. But because there's a double hit in that same gene, you have perhaps earlier onset or more severity in that particular streak. And so it may be the only thing that shows up. And that's what happened in this girl with this ILVEN that turned out to show evidence of linear porokeratosis. She had a genomic situation from her father in all of her cells with a change in a phosphomevalonate kinase, plus in the same gene, she had a somatic variant, which was only in the lesions with a different genetic change, but in the same gene, type 2 mosaicism. Well, it turns out that ILVEN is not one disease, but is really a heterogeneous mosaic disorder, even beyond the association with porokeratosis I just showed you. Here's a patient with ILVEN due to a common mutation in HRAS. Another patient with child nevus, mutation in the dehydrogenase here in the cholesterol biosynthesis pathway, just as the same pathway with porokeratosis. I told you earlier about the GJA1 variants, and in fact showed you a patient at the top who had a variant that created this particular change at her 44th amino acid. And here's a patient who just has that, showing it in a single streak down the arm, diagnosed as ILVEN. And here's an interesting patient who it turned out had a background of CARD14 that hadn't manifested except in this one streak that had a change in keratin 10 with a very common point mutation at this site. And so this is actually someone who had a background of CARD14, different gene on top of it, but in a way is like a type 2 mosaicism because they're two diseases that are occurring at the same location and can make it theoretically a more severe or earlier onset of change, or just specifically, as in this case, at that particular site. So we've talked a lot about some of the newer discoveries, but how are these discoveries in new technology changing the treatment of monogenic skin disorder? And there's so much going on here that I'm going to very quickly go through this and make some specific citations here for you. So here's what we talked about before: old-time Sanger sequencing, now largely yielding to whole exome sequencing and even whole genome sequencing. And there is the concept of using this information and knowing what the gene is to move towards gene correction. One example is some research going on now in which you can actually correct in vitro the patient's own cells and then create autologous epidermal sheets, which can be transplanted. You can do adenine base editing is another idea that's not really in prime time yet, but is moving forward using, for example, retroorbital injection of an adeno-associated virus that could edit the progeria gene, the lamin A, in a mouse model of progeria. Also, adenine-based editing has been published of embryos with the transglutaminase 1 variants. Now, this has not been taken to term or anything, but it shows that you can actually make a correction in utero, potentially, if you can diagnose this prenatally and early enough. Now, that's not moving forward as quickly as the concept of gene supplementation. And I do want to remind you that the trials have now been completed in terms of phase 3, or an open label now, for using a topical gene therapy for correcting the collagen 7 defect in recessive dystrophic EB. And this is now moving forward as well towards lamellar ichthyosis and correcting the transglutaminase 1 deficiency, showing you some results in the phase 1-2 trials that have been reported here on the right. We're very excited about topical gene therapy, and I'll just mention that this is a technology where you can rub the topical gene therapy onto the skin and create factories out of our skin cells, because it's in a herpes vector that's not active, that's not able to cause disease, but is able to deliver the collagen 7 gene and prove basically make this a pharmacologic treatment, but leveraging the concept of gene therapy. I want to just mention to you a little bit more about some of these. This is cell therapy with retroviral gene-corrected graft. This was originally published back in 2006 for a patient with junctional EB, and a follow-up showing persistence for at least 6.5 years, no blistering in those affected areas. And this concept was then moved forward by the same group. I'm sure you remember this, but again, this concept in a boy who had junctional EB of this type, who was hospitalized and just wasn't making any progress with 60% skin loss. They were able to take his own keratinocytes from some of the few areas that didn't have the blistering, insert the full-length LAMB3 gene using a retroviral vector. We're able to show with then grafting that there was, in fact, the LAMB3 being expressed. And this is 5 years after transplantation in a follow-up, and I understand he's still doing well. Those areas that were transplanted have not shown any blistering at all. The few areas that were not affected originally and did not have transplantation are areas where he's had, as you can see, some pretty severe blistering. So the concept can work, and Stanford has been a leader, and this has now moved forward in real clinical trials in looking at the possibility for recessive dystrophic EB of doing the same. And as you can see here in these images, these patients are doing very well, not as well as the junctional EB where there really isn't any blistering, but still improvement in quality of life and much less blistering, even over time in these patients without any major adverse events. I will mention that when someone has a recessive disorder in which they've theoretically never seen the antigen that is then introduced by grafting it on and having it produced there would be a risk of the development of antibodies directed against that newly recognized protein. So there has been some selectivity in the patients who are in these trials. It turns out that the collagen 7 is a very immunogenic protein. As you know, we can have epidermolysis bullosa acquisita when one produces anti-collagen 7 antibodies with an immunobullous disorder. So it turns out that about 60% of those who have recessive dystrophic EB have seen at least the immunogenic portion early on in the collagen 7 protein, because of the fact that their defect, at least in one of the alleles, is after that. And so those are the patients who are able to be included in these trials. I will also mention that many patients with recessive dystrophic EB have at least low-grade antibodies in their circulation. Oops, let me just move on to this. Oops, there we go. I also want to bring up the concept of Revertant mosaicism as natural gene therapy. I've seen this in a few of my patients, and theoretically it can be used to expand the patient's own cells from these revertant areas for grafting without even having to introduce anything. This is a patient of mine. You can see she's got recessive dystrophic EB, and over time, we were able to show a large area on her arm and also an area on the side of her back that never experienced blistering. And we're able to show that, in fact, in this, what is revertant skin, she was able to produce the collagen 7, which gives her the opportunity then to have grafting with that. Well, where is cell therapy heading? Well, now we can basically introduce, we can choose clones for best stemness, because then we can maximally expand these. We can do safety studies like tumorigenic assays, and get rid of any that there might be a risk for viruses that could give skin cancer down the road. There are early studies in progress to use induced pluripotent stem cells to make this scalable and speed the processing to have enough cells to increase the area of grafting. I'm intrigued too by the concept of spray-on keratinocytes that have the gene correction, so you don't even have to be creating these sheets and putting them on. This is being done right now for burns, and we'll be keeping our eye on the possibility of doing this and then more easily doing touch-ups or maybe even doing smaller areas as a result. Of course, doing this right now is a surgical procedure and requires graft take. And then assessing the mucosal surfaces, which are a big problem for these patients, is still a limitation. Well, topical gene therapy is moving forward. I talked about this a little bit before. I just want to show you some of the results here shown with the topical gene therapy for collagen 7. And here you can see good deposition at the basement membrane zone. You can see the response rate in terms of having the primary endpoint of complete closure at 6 months was clearly statistically significant here, occurring in 67% of those treated. And of course, this is one of the best pictures in part of that, but it's quite dramatic. And I think you can see at the end of the study, just topically applying that, how much better this patient is. And I will say that this therapy hopefully will be coming out in the next year, so it might be commercially available. I want to mention exon skipping with antisense oligonucleotides. So this is the concept that there can be an antisense oligonucleotide that specifically recognizes the mutant sequence and then interferes with splicing in that region, allowing the mutation to be bypassed. And if you have certain regions that are particularly smaller regions, or in which one can do that based on the ability to splice it out, then it's potentially a great technology. And this has been used in grafted EB mouse models, but more important, it's been used in hundreds of patients with Duchenne's muscular dystrophy. So we have really good proof of concept with another disorder. This technology is now available theoretically for several gene locations. And that encompasses a lot of the patients with recessive dystrophic EB and dominant dystrophic EB as well, actually, but recessive dystrophic EB, where at least one of the alleles is affected by this. And in fact, there is a trial moving forward with exon 73 as the site, which is a site in 8 to 10% of those with recessive dystrophic EB, but more than 50% with dominant dystrophic EB. So I hope this is something that will be seen in the future. This is also topical, but it can be given intravenously to reach mucosal areas on a theoretical basis. The concept of read-through is one I want to mention. You've probably heard about that when there are premature termination codons that just stop the translation of the gene. And we see this in 46% of patients with recessive dystrophic EB. We also, I should mention, know that 35%, probably even less, normal levels of collagen 7 should be enough to prevent against blistering. So it turns out that aminoglycosides, including gentamicin, which of course has been around a long time, are able to do this. And in studies from the group at University of California, at Southern California, have put together several of these trials that suggest that you can just give 2 weeks of intravenous administration of gentamicin and see improvement at 1 month and 3 months. And at least so far, there's no evidence of renal or ototoxicity, which is what we have been worried about, of course, with the use of gentamicin. It's also been shown to be effective for LAMB3 mutations in early studies as well. Can we use this topically? Yes, except that one of the problems is that in studies, the gentamicin ointment has been made up and is a higher concentration than what we typically have commercially available. So the 0.5% may work better than what we have, the 0.1% here. Now, I'm going to spend the rest of the time talking about targeting downstream. We've been talking about gene changes, but what about targeting at the level, for example, of the protein or its downstream changes? So protein therapy is available. I'm going to show you this for X-linked hypohidrotic ectodermal dysplasia, where in early studies in mouse and then dog models, it showed that you can introduce it not just in utero, but also in the early postnatal period. And that led to a lot of excitement and a phase 2 trial in X-linked hypohidrotic ectodermal dysplasia given to male newborns. So you had to know up front that they were going to have this. And this was a fusion of the ectodisplacin protein with an FC. And this fusion protein then was given in doses twice weekly in a total of 6 babies, and it had no effect. But it's known that there are FC receptors in the gut of children, and of course they swallow amniotic fluid as fetuses. So in fact, there was a subsequent trial in which there was injected this recombinant fusion protein with the FC on it into the amniotic cavity. And now we see some success. These babies, given at 26, 31 weeks, had normal salivation, normal sweat gland density and function, and normal tooth germs. They did not have a change in their faces. They did not have a change in their propensity to have sparser hair, but maybe it was just a matter of timing for this. So studies are ongoing. And I will tell you as well that this type of recombinant protein is also in trials for recessive dystrophic EB. In earlier studies, in other models, it suggested that giving it IV helps wounds, reduces fibrosis, and also can get to both skin and mucosa. So a big advantage of this potentially in being able to get to mucosal regions as well. Well, what about downstream even of the gene itself? Well, we have the data that we provided more than 10 years ago, looking at the cholesterol biosynthesis pathway and recognizing that patients who had child syndrome had a defect that prevented their production of the cholesterol in skin. We tried giving cholesterol, but that did not work. But if you look upstream, the enzyme that is rate limiting for this pathway is a CoA reductase that is inhibited by statins. So we were able to put together a topical formulation that gave back the cholesterol, but also provided the statin. And one of the reasons we wanted to give back the cholesterol is because statins can dry the skin. We wanted to make sure that there was still cholesterol coming out and available. And that has worked very well for people all around the world. Here's showing you one of my patients in that early trial with remarkable improvement in just 6 weeks, and she was able to wear her prosthesis and have a much more normal life. We'll go back to our discussion about porokeratosis, and I'm showing you here on the bottom my patient that I showed you earlier with the ILVEN. And what I want you to notice is that just by a month after starting this combination, because once more we have a blockade within this cholesterol biosynthesis pathway, she saw dramatic improvement. She was able to stop the retinoids that she's on. And here you can see a little bit further down the road, about almost 2 years down the road, you can barely see it in some of these areas, off of retinoids and just with this topical application. Now, what about CARD14? Let's come back to this as another way to target. This is the concept of biologics. I mentioned that with CARD14 variants, it's often recalcitrant to medicines that we will often use for treating PRP or psoriasis. Here's the pathway showing those activated mutations, activating mutations that drive increases in IL-23 and Th17 signaling. And I will tell you that the treatment of choice now is ustekinumab, but Th17 inhibition should also be affected and has been in some cases. And you can see the dramatic response. The response to this group of agents has been better than anything else. Now, I also mentioned that you can have CARD14 as a variant for ILVEN, and in fact, Veronica Kinsler's group has recently published this set of patients in which here we have ILVEN due to CARD14 treated with ustekinumab with a dramatic response. I thought this was interesting, so I just want to show you this concept of revertant mosaicism in CARD14-driven PRP in the skip areas, because I think it might teach us about the fact that there may be something going on in anyone with PRP with these skip areas where there's clearance, and it's probably going to be genetically, but perhaps epigenetically driven. So here is a study in which these areas that were skip areas were specifically studied and were found to have a revertant mosaicism. So it corrected the abnormality leading to the clinical manifestations in these disorders, and kind of like what we see in ichthyosis with confetti, the same concept of revertant mosaicism in these affected areas. Now, I want to move on to talk about what's happened in the field of ichthyosis because of recognition of what the immune skewing is there. I'm going to try to keep this short and get to the punchline because I know our time is short, but we did studies on fairly large numbers of patients across the different types of congenital ichthyosis. A few years back, we published I published an article back in 2017 showing that there was a shift towards the Th17, IL-23, IL-36 signaling pathway. And we've recently come out with a new article. Oh, it says unpublished, but it recently came out in Journal of Investigative Dermatology as Kim et al. Looking at RNA-seq from biopsies of patients with congenital ichthyosis. And if you look across the top 100 differentially expressed genes, the top 30 include largely those from the Th17 pathway, as shown here. I want to also mention that when we look in the blood of these patients, we see increases in interleukin 17. And we can also see evidence of systemic immune activation. I'm showing you here results from flow studies looking at cell expression. And the important take-home point is that these patients with ichthyosis have excessive inducible co-stimulator molecule activation, a sign of systemic immune activation that is higher than in atopic dermatitis or in psoriasis. And if we look at the expression patterns of these cells, there's an elevation in interleukin 17 and also an elevation in interleukin 22 producing T cells that cluster with the severity of the ichthyosis and particularly the severity of the erythema itself. So I look at these results and I say, wow, these forms of ichthyosis that we thought were just involving the skin actually are causing activation of immunity systemically. That may mean that we want to treat them with systemic agents, but it also means that we need to think about comorbidities and perhaps the kind of comorbidities that we see in psoriasis, like joint disease or metabolic issues. And indeed, we have now found that many patients with ichthyosis have joint disease, including in the first decade of life in many who have harlequin ichthyosis. So ichthyosis share the psoriasis-like pattern, and we need to ask whether it's just because they're being bombarded with a poor barrier by organisms at the surface and there's a Th17 response, or at least in some forms of ichthyosis, could it be that like psoriasis, this skewing of Th17 pathway drives the inflammation and scaling? And if that's the case, could we use anti-psoriasis biologics to treat? And I'm just going to quickly show you that, in fact, in some patients with ichthyosis, those biologics have changed their lives. It has happened with everybody that's now been treated with a fairly rare variant called erythrokeratodermia with cardiomyopathy that is due to a variant in the gene encoding desmoplakin. And these children, after the first years of life, have progressive cardiomyopathy. The girl on the left has already had a cardiac transplant. But unfortunately, even immunosuppressive medicines were not helping with her severe itch, which actually required topical steroids twice daily, despite her poor barrier. I think you can see that she looks a bit cushiony. Look at those cheeks on the left. And 16 weeks after starting the ustekinumab in this situation, and I would say, having stopped the topical steroids 2 weeks after starting this, you can see that she looks like a different girl and her life has been changed. Also, the boy on the right had the same situation. And since that time, this is, for example, a baby published who was already on the cardiac transplant list as an infant, and within 1 month of starting the medication was off the cardiac transplant list. Here's another patient of mine who was just miserable. He came in thought to have Netherton syndrome. Notice the sparse, somewhat wiry hair, which is a feature of this disorder. He also had failure to thrive, but didn't have Netherton's, had this disease, and has done very well on ustekinumab. In fact, we had to stop him at one point to give him his live immunization, and he flared terribly. Other anecdotal reports: SAM syndrome with reduced itch, weight gain, fewer infections, and clearance of skin in some patients, but not others. This has been reported in New England Journal of Medicine, and showing you here some patients with Netherton syndrome who have done well with secukinumab. I've had patients with ustekinumab. There have been reported patients also even with dupilumab who have done well with Netherton syndrome, and we cannot yet predict who will do well or not. This is a patient with the NEPAL-4 variant of congenital ichthyosiform erythroderma who did well with ustekinumab, and I have seen that as well. This one particular subtype of congenital ichthyosiform erythroderma seems to do very well with ustekinumab or secukinumab or probably any other IL-23 Th17 pathway. Some of the other patients who've done well with this, and again, ongoing trials now, we have several patients who've had some improvement, including with harlequin ichthyosis with ustekinumab. There's a trial coming up with dupilumab for pruritic genetic disorders that go beyond just Netherton syndrome and this form of CIE. I want to talk about Netherton syndrome because I think ultimately the best type of treatment will be looking for genetic changes, trying to reverse the downstream effect of the genetic changes in SPINK5, which leads to the deficiency of a protein called LECT. The result is an increase in kallikreins 5 and 17 in particular, which are known to break down the skin barrier proteins and drive skin inflammation as well. So new therapies in development include kallikrein inhibitors. They can be topically, they can be systemically, or adding even LECT protein itself, and we'll be on the lookout for that. I do want to also mention some other thought processes because it's not just all about the inflammation or the scaling or breakdown of skin. This is recessive dystrophic EB, and of course we know that there's significant morbidity because of the fibrosis and then that related risk of squamous cell carcinoma. So I do want to mention losartan in mouse studies, as shown here, when started fairly early on, did a beautiful job in preventing the fusion of the paws in the mouse models. There's a trial ongoing right now in Germany to see if losartan at doses used for humans can prevent the mitten deformities. But I think this kind of concept, and others are being looked at as well, of inhibiting the fibrosis will be at least an adjunctive technique for our patients with recessive dystrophic EB. So finally, some take-home message. First, our understanding of genodermatosis has exponentially grown because of the availability of technology. Second, that discoveries about the underlying basis of genetic disorders have translated into new and repurposed therapy for patients with genetic disorders, and they will guide innovative treatment in the future. And I want to remind that it's really because of the new technology, next generation sequencing, big data analysis, that we're ultimately going to get to personalized mutation-based gene and pharmacologic therapy. And I'm showing you a magnified view of a tape strip. I'm sure we've all, even as children, put a piece of tape on our skin, pulled it up and said, ooh, look, I got some of my skin on here. And I think this is a beautiful technique that we've now employed in pediatric patients who, of course, are so impacted by these disorders, to try to understand what's going on. We can use tape strip skin to look at transcriptomics. We can use it for lipidomics. We can use it for metabolomics. There's enough here for big data analysis. And although we use swabs for the microbiome, we could use it for that as well. And we can couple that, of course, with blood studies or studies that look at the genetics to really get a very comprehensive picture for that individual that hopefully will help us to direct which agent to choose in the future first to treat these genetic disorders. And with that, I'm going to stop and thank you for your attention. And I'd be happy to answer any questions that you might have.
Thank you, Dr. Paller. That was absolutely wonderful and did generate a lot of questions. So I will field those to you now. So someone was wondering what could explain the glutamine administration improvement in atopic dermatitis and CARD11.
Yeah, that's a really good question. And I think glutamine is part of a pathway that I think helps with, I'm remembering the whole Th1 pathway. I can't actually remember the exact pathway. If that person wants to send me an email, I'll be happy to send that to you because I actually have that information. But it actually, I think, is part of the NF-kappa B pathway through its pathway. I can't exactly remember right now, but happy to send you that. I hid my controls, so I'm trying to get rid of my slides. If anybody wants to help me with that centrally, that would be great. Because you're going to now see a blue screen. Let me just see if I can get you open. Let me try this. I don't know. Sorry.
No worries.
I can't, I know you can't see me.
It's okay. The next question, they say, thanks for an excellent presentation. They have 2 siblings with clinically compatible with SC4ML deficiency, presenting with psoriasiform dermatitis, ocular abnormalities, intellectual disabilities, and they were found to have the MSMO1 homozygous variant through whole exome sequencing, and they wanted to know if you had any experience with treating this condition.
No, I actually have not had a patient who had that. That's very rare. And so I haven't, again, I think with all of these, when we know what underlies it, and then we can understand functionally what is happening, what pathways may be involved, I think that's essentially how we have to go about thinking about new strategies. And if there's a way to try to repurpose, that's always fantastic, because we have to get industry to invest in these orphan diseases that are so much harder to study.
Okay, amazing. And I do want to be conscious of your time. Are you okay with a few more questions?
Absolutely.
Amazing. So they wanted to go back for the next question to the topical collagen 7 delivered by the herpes virus. They were wondering how long the RNA is expressed after the topical application.
Oh, that's a very good question.
Yeah, for how long the corrected protein stays for.
I went very quickly through this. Obviously, there's so much to say. So this is now being put on every week. So patients at this point who are in these trials are coming in once a week. They don't have to come in once a week, but they can have it done once a week. And for those who are more severely affected, it does make a difference if they go without for a period of time. So once a week, they get it. It's a very easy application, just basically dotted onto the wounds and then left in place for the next 24 hours. When this comes out commercially, the recommendation will be weekly application for patients who have more severe disease.
Amazing. And then someone was wondering, how well understood are the pathways by which monogenic inflammatory disorders such as CAPE lead to inflammation in the skin? Is targeting innate versus adaptive immunity more important?
So I'm sorry, such as what?
For example, CAPE, C-A-P-E.
Okay. So we are repurposing what we have. Our targeting of the adaptive immune system is what's really making a difference. But I do agree that with all of these inflammatory skin disorders, there's such a strong innate immune component, and it is like a cyclic process with stimulation of keratinocyte production of these innate immune cytokines that drives these. So I think we're going to know that a little bit more as we start to see more studies coming out, let's say with a biologic directed against interleukin 36, where that is something that is produced by the keratinocytes. Probably one of the reasons why biologics for psoriasis directed against TNF have been so successful is because of that amplification of what's going on in the immune system. Even though the skewing that you would think that the best targets, and they do tend to be a little more effective, are your IL-23 Th17. The TNF alpha recycling that goes on because of that whole innate cascade, I think also has been very effective because of that. But looking upstream, even when you have what stimulates and really activates the skin to make atopic dermatitis, to make psoriasis, and to make some of these rare genetic disorders, I think looking at the ability to block early on some of these innate cytokines and their signaling is also going to be very interesting to look at as a possibility.
Thank you. And then one last question here before we wrap up. Do you think that the T cell activation phenotypes in ichthyosis patients are a result of the mutations and barrier defects, or both?
I don't know if there's anything direct from the mutations and whether the genetic change in itself predisposes. No one has looked at that. I mean, so I really don't know. But I am sure that the barrier defect plays a role, because we know when we have barrier defects, we don't know the mechanism, but we do have activation of these pathways, presumably, at least in part, through microorganisms that activate them, but also through other environmental changes. Epigenetics is likely playing a role here and has not really been explored other than very cursorily. So I think that that's wide open for investigation to better understand what's happening that leads to the phenotypic features that we see.
Amazing. Well, thank you so much. If any other questions roll in, I'll be sure to send them your way, but we
and that would be fine. And send me the question too about, I'm sorry, I'm just not remembering exactly how the glutamine is working, but I've looked at that.
Yeah, no worries. I'll send that your way. Thank you so much.
Okay. Goodbye, everybody. Thanks a lot.
Goodbye.